Good morning, and thank you for inviting me to speak here today. I'm so excited to be here because I look out at this audience and I know so many of you, and I know so many of you are doing really good work in the Lyme community. I see a lot of different patient groups represented here, so I'm really just delighted to be here and be able to talk to you today. And what I'm going to talk to you about is my Lyme data. I'm going to talk about why we need it, what it is intended to accomplish, some preliminary results, and why I think it can accelerate research in Lyme disease. And before that, I do that, though, I'm going to spend just a few minutes talking about LymeDisease.org, so you can put us in context. We were founded in 1989, and the center of our focus is empowerment. We have always been about engaging the grassroots and empowering the individual patient. And we've done that by providing patients with information that they need to get diagnosed and treated. And we've also done that by conducting large-scale surveys. So we've done surveys of, say, 5 or 8 or 9,000 people and published those, and we've also used them to help inform healthcare policy. A couple of years ago, the FDA came out and said that they were opposed to laboratory-developed tests. They were going to change the regulations, and we worked with some other groups, and within 2 weeks, we pulled together 9,000 responses to a survey that we did for the FDA on what patients were concerned about with testing for Lyme disease, and ended up having a robust discussion with the FDA. They didn't exactly go where we wanted them to go, but the fact of the matter was we were able to say, not here's what I think, or here's what my organization thinks is important, but here's what Lyme patients think, and we know because we ask them. And so this here is a definition of empowerment. It's interesting, this definition was endorsed by the FDA, the CDC, many government agencies. I read it the other day and was just really sort of surprised and thought, oh, well, that's it exactly. That's exactly what we do. So empowerment is group-based participatory processes through which marginalized, oppressed individuals gain greater control over their lives, acquire valued resources and basic rights, and achieve important life goals and reduce societal marginalization. And that's basically what our focus is. So nobody in this room is going to be surprised by this slide. What this slide shows is the amount of funding that is spent for other infectious diseases and the amount of funding has been spent on Lyme disease. It's from a study that was done by Goswami, and what he did was he took a look at the number of trials that were entered into clinicaltrials.gov, and he simply noted the number that had been conducted. And as you can see, HIV/AIDS has had a lot of studies, hepatitis C has had a lot of studies, Lyme disease has really been a neglected disease on the research front. And the last federal treatment trial was funded over 15 years ago. So, you know, it really has become apparent that if we want something to change here, we have to change it. We have to step up and simply do the work. And you might think that the answer would be to do more randomized controlled trials, but this is Rob Califf, who until recently headed the FDA. I sat on an executive committee with him at PCORnet, which is one of the nation's largest big data trials. And what he likes to say is traditional trials are great, but they take too long, they cost too much, and they don't apply to most people. And it's easy to see by looking at this table what he's talking about. So if you take, say, the Klempner trial, for example, you'll see that they screened 1,900 people to achieve 129 people being enrolled in their studies, and it took them 3.3 years to do this. And of course, then there was analysis and publication. So these trials are very expensive. They're taking, 5 years to run. And the bottom line is that you can't get definitive answers with this small of a sample size. So Gordon Guyatt, who's a leading voice in evidence-based medicine, he says, providing definitive answers in the face of low events and small to moderate treatment effects necessitates sample sizes in the thousands or tens of thousands. This is a slide from Kravitz. It's a fabulous article. It's about the heterogeneity of treatment effects. And what he's talking about is, if you take a look at this curve here, this is a normal distribution curve of a disease. And the question when you're looking at trials that are done in Lyme disease is, well, where was the sample drawn from? We know we have highly selective trials. Did they draw the sample size from sample 4 or sample 2? Because those are probably very different samples. They're probably going to achieve very different results. And the fact that we have the randomized control trials that we've had in Lyme disease have been so selective in their screening processes means we've left out most of the people. And the same thing happens with average treatment effects. You know, most of the trials that have been done in Lyme disease take an average together, the treatment effects. But if somebody has done really well on a protocol and somebody else has done really poorly on a protocol, you're going to come up with a null effect. This, again, is from Kravitz. The ability to be able to go in and start doing subgroup analysis, determining which people are getting better, why are they getting better, which people aren't doing better, what is the zone of no clinical meaningful effect. You know, in other diseases, they're looking at things like, do we have responders? Do we have partial responders? Do we have people who are fast responders, slow responders? Do we have people who respond completely and then relapse? And these are the sorts of things we need to be doing in Lyme, but we're really a long way off from being able to do that now. So unlike traditional trials, patient registries let us enroll diverse patient populations, so everybody's on the bus. They allow us to evaluate care as it is actually provided in real-world practice. So this is what are physicians actually prescribing and how are the patients actually responding. They allow us to assess complex treatment patterns and treatment combinations. You know, if you look at most of the trials that have been done in Lyme disease, it's one treatment, and most of them are the same treatment, and maybe one treatment followed by another treatment, and you really don't have multiple treatments being tried at a time. You can do this in a patient registry. And they offer the ability to evaluate patient outcomes when clinical trials are not practical or are difficult to conduct. For example, when you're looking at treatment effects over a long period of time, and we know that 30 days probably is not what we should be looking at in terms of clinical trials, probably 90 days is not what we should be looking at, but with a patient registry, you can actually do longitudinal long-term studies fairly easily. So you can have the recognition of the need for doing big data, and you can also have the organizational capacity to do it. But the question is, what is it that's driving it right now? And today, I think we're sitting on this really unique space and time. It's just that there's so much happening right now. So big data has been enabled by rapid advances in technology. Precision medicine is looking at biomarkers in ways we've never been able to before. Patient-centered research is saying, you know, we could fund this research, but is it something that's meaningful and matters to patients? And if it's not, should we be spending government funding on it? Personalized medicine, will this treatment work for that patient? And the democratization of science. And the democratization of science actually ends up being a big deal. So this is a cover of the Lyme Times, which is one of the publications that we produce, and it's about the democratization of science. All of these groups are involved to some extent with the democratization of science right now. Sort of surprising. You see the FDA, the CDC, the NIH, PCORI, and they all have like little arms that are involved in this. It's not like it's the mainstream of what they're doing, but they all have their little segments that are doing this. And the thing about the democratization of science is it literally turns science on its head. Instead of being driven from the top down by researchers, it's driven from the bottom up by patients. And that becomes the way in which you can accomplish studies in a really inexpensive, quick way. And of course, in Lyme disease, there's a lot of frustration and pent-up demand with patients wanting to be able to do something. And as one person who's involved in my Lyme Data said, you know, when I was at my sickest, I couldn't do much, but I could do this. So it's literally of the people, by the people, and for the people. And for us, it means that it was designed by patients, and it's designed to benefit patients. in its entirety. So that's the driving force. Before we launched My Lyme Data, we had a couple of big surveys that we published. One of them was on the severity of chronic illness compared to other chronic illnesses. We used standard government questions, and we're able to compare Lyme disease with many other diseases across the spectrum. And the other was on access to care and the burden of the disease on patients. And both of these studies are jam-packed with data. We are an organization that is literally drowning in data. And if you're looking for information about what percentage of people have co-infections who have chronic Lyme, I encourage you to take a look at these two studies because they're in peer-reviewed journals, and we really packed a lot of data into them. Now, turning to My Lyme Data. My Lyme Data was just recently launched, 2015, and we expect it to gather more data about Lyme disease than any research study has done before. And that sounds like it's a big claim, except when you remember back to that slide that I showed you, the little table about the largest size study, and you see that that was Klempner, and it was 129 people. So we have over 7,000 people involved today. We have millions of data points. It's clear to me today that we are the largest research study ever conducted in Lyme disease. Our goal is to go from 7,000 people to 10,000 people. You know, in patient registries, the hardest thing to do is to actually enroll the patients in the registry. It's the same thing with research. The hardest piece is to recruit patients to be involved in research. But we had this phenomenal amount of interest in the registry, so today we have 7,000 people involved. And as Woody Allen says, 80% of life is showing up. So the purpose of My Lyme Data is, we have various purposes here, but the ones that are the most important I've highlighted. It's to identify subgroups, determine the effectiveness of specific treatments, improve quality of care, inform research priorities, and facilitate research. So it's called a patient registry, but it's also a research platform, which means that it can help researchers recruit patients and get them involved in studies. It can also help researchers do long-term follow-up with patients after a study is done. This is where we are on the timeline. We launched phase 1 in 2015. We ask about exposure, we ask about diagnosis, symptoms, treatment, and so forth, quality of life, cost of illness. Phase 2, we just launched in November of this last year. Phase 2 encompasses all of those things, and it also turns My Lyme Data into a prospective longitudinal study, which means we're asking people, what treatments are you on? What are your symptoms today? Have they improved or have they not improved over the last 3 months? So we're beginning to track this on a longitudinal basis. We also added in information about family history. Does Lyme run in your family? We added in information about genetics. Have you had a genetic test done? We ask about biospecimens. Have you made a donation to a biorepository? If so, which one? We want to know. And we're just beginning now in 2017. We're beginning to work with some researchers, big data researchers, so, by and large, a different group of people who are being brought into the fold, and we're very excited about that. And this is an article that Dr. Stricker and I published that's on the promise of big data, companion diagnostics, and precision medicine. So we wanted to start pulling some of the data out just on a preliminary basis to see what we could find. And the first thing we did was we asked a very simple question. Do patients get better who are diagnosed early? And we all think that's true, but do we know it's true? What do we know? So what we did was we took a look at patients who were diagnosed early in the registry who characterize themselves as being well compared to patients who characterize themselves as being sick. And what we found was that patients who were diagnosed early, the rate of them that reported being well was about 280% more than patients who were diagnosed late. So that means that early diagnosis and treatment is very important. But the other thing that we found, which is equally important, is that early diagnosis was not enough. 68% of the people who are in the registry who were diagnosed early remain ill. And so I think that these findings suggest the importance of doing of early diagnosis, early treatment, and also finding better treatments for patients. But most of the patients in the registry are diagnosed late. We have 73% of the patients in the registry report that they were diagnosed with untreated late Lyme, which means they weren't diagnosed until at least 6 months after the onset of their symptoms. I think that's a really common story among patients with chronic Lyme. And what you see over time here, this is from another study that we published, is you see that the general population, if you ask them, how are you doing? Well, how would you describe your health? Is it excellent? Is it very good? Is it good? Is it fair? Or is it poor? It's a standard question that's asked on many CDC questionnaires and is used extensively. And what you'll find is in the normal population, 16% will report that they have fair or poor health. Early Lyme, it's 23%. Once you're out at 6 to 12 months, the number of Lyme patients reporting that they have fair or poor health is 56%, and at 5 to 10 years, you're up to 72%. And so this is a really important factor in terms of catching people before they start to have serious quality of life issues. This is a simple concept that's known outside of Lyme. It has nothing to do with Lyme, but it just shows that people who have chronic illnesses are the heaviest users of health care. That's, it's up at the 96% of health care visits are from patients who have chronic conditions. And this is something that's being looked at broadly by the government generally. This is a study that was done by Zhang in 2002, and I've taken and I've updated the cost for inflation. And essentially what this study shows is that if you treat a person at tick bite, it's going to cost you $400. If you treat a person with late Lyme, it's $20,000 a year. So a 12-fold increase by waiting. And the other thing that this shows is it shows that people who have the direct medical costs, which is that $3,000 line there, is very small compared to the total cost. So $3,000 compared to $10,000. That means most of your costs are being incurred by loss of productivity and non-medical costs. And we know that that cost is a large cost to healthcare systems. I mean, we've always known it was a problem for Lyme patients and their families, but it's a big problem for healthcare systems. This is a study that's out of Johns Hopkins. It was done by John Alcott and Emily Adrian. And essentially what they did was they looked at 47 million health insurance participants and identified those who had Lyme disease. They were looking at early Lyme disease. And they found in the first year following diagnosis, there were 87% more visits to the doctor, 71% more visits to ER, and that Lyme patients incurred $3,000 more annually than matched controls and direct medical costs. So this tells us that it's not only expensive for the patients, their families, the community at large, which may be bearing the cost of disability, but it's also extremely expensive for the healthcare systems. So finding better treatments and identifying people earlier is a critical issue. And we found the same thing in our study, which was published a couple of years ago. In our case, the direct healthcare costs, this was utilization really we were looking at, was higher, but that's because we were looking at people with chronic Lyme disease. And so what we found was, compared to the general population, chronic Lyme patients visited healthcare providers 5 times more often, and the emergency departments more than twice as often as the normal population. And they were almost twice as likely to stay overnight in a hospital, and were roughly 6 times more likely to receive home care visits. This shows essentially what happens to patients who are not diagnosed early. What happens with Lyme disease is that it literally stops people in their tracks. People who report having had to stop work are 43%. That's very high. I think it compares with something like 6% in the general population, or 16%, some smaller number. And the number that have had to reduce their hours or change the nature of their work is about 26%. So it has a very profound impact on what the person is able to do. And this has been mentioned a couple of times here today. This is the poor sensitivity of our tests, and this shows that roughly 46% sensitivity for the tests that are being done for Lyme disease. If we think that we must diagnose earlier, then better testing is key. And interestingly, that type of result we are finding in the Lyme Data Registry. We found there is 50% of patients in Lyme Data report that faulty testing delayed their diagnosis, 37% because of false negative lab tests, 13% who had positive lab tests who were dismissed as false positives, and that happens lots of time because there is no Lyme here, is what patients are being told. So these maps here, there are 4 of them. One is the CDC total cases, and then next to it on the right is the canine lab cases. You know, they test all the dogs that come in, or IDEXX does this as a standardized test, and they reveal very different pictures of where you're going to find Lyme in the United States. You can see that the canine map is far more filled out than the CDC map. And the same thing on the 2 maps below. Below is the number of patients who've requested ILADS physician referrals, which ILADS was kind enough to share with me, and then also the number of patients in my Lyme Data who've been diagnosed with Lyme disease. And you can see that those 3 maps really present very different pictures of what is your risk of contracting Lyme disease depending on where you live. And it seems to me that it's a bit early for us to be saying to patients there is no Lyme here. We don't know. We don't have enough information. So I blew out at the top the Arizona figures, thinking they might be of interest to this audience. CDC says 21 cases. The canine cases were 1,300. The requests for referrals to ILADS physicians were 156, and those enrolled in my Lyme Data are 76. So what do we need? We need better tests, better treatments, and better research. And you know, they say that the best way to predict the future is to create this. Right now, we have the opportunity to do it. So let me tell you how this works. Patient registries develop interventions through partnerships. It's all about the partnerships. So you start a patient registry, you start looking for biospecimen repository samples. This leads to natural history studies, disease information increases, you're able to identify clinical endpoint and biomarkers more easily, you're able to identify off-label uses of pharmaceutical medications that are currently approved by the FDA, and then you develop new hypotheses, new research hypotheses. Once this is done and somebody wants to do a clinical trial, you have a research-ready population. You have 80% of the people who are in our registry say that they're interested in participating in research. You're able to start evaluating the interventions more quickly, and when you go to the FDA, they're more likely to look upon you favorably because you've had substantial patient involvement in the process. And then when it comes time to do phase 4 trials, where you're really doing the studies after the clinical trial has ended, we're able to do that type of longitudinal, long-term follow-up quite easily. So this is the concept. This is the model that we're trying to get going, the machine that we're building. Here's where we're heading. We have 7,000 patients. We're looking to have 10,000 enrolled this year. We're looking for clinician outreach, researcher outreach. We're working with patient groups, working with lab test companies. We need to start getting involved in genetic testing, and we need to be involved with blood and tissue banks. The thing is that you want to have the most complete data set that you can so that when researchers come to you, you can provide them with really robust data with a lot of people. So I want to thank you for giving me the opportunity to speak with you today. We're really excited about my Lyme Data. We're looking for clinicians, physicians, researchers, epidemiologists, biostatisticians. The list goes on and on and on. If you're interested in being involved in this effort, we invite you to join us.
Thank you. We do have a few minutes before we go to lunch for questions. Anyone have any questions? Yes.
What is required to call yourself Lyme disease?
Oh, that's interesting. That's a good question. So, and we have wrestled with this over the years, over 10 years of our surveys, you know, figuring out who's on the bus, who's off the bus. And generally, because it's a patient registry, we err on the side of everybody on the bus. And a researcher can decide who they don't want in their sample, right? Because it's very easy. You just exclude these people. But what we do is we ask people, have you been diagnosed by a healthcare provider with Lyme disease? If you haven't, you can't get on our bus. That's like a threshold requirement. Then we ask people about whether they were exposed to a tick. We ask them whether they've had diagnostic tests. We ask them if they had an EM rash. All of that is data that is available, but we don't use it to exclude people. A researcher, I mean, actually, one of the studies that we did, we compared people who had, everybody on the bus who'd been diagnosed by a physician, and then those who just had an EM rash or CDC two-tiered testing. And so we were able to actually compare those two groups. But now it's data that's available once you get down to that level.
Great presentation, Lorraine, and no, I'm not going to give you an off-the-wall question. But I think this is important that, because you and I have already discussed this, and the kinds of information that I get in from patients, a lot of them are concerned about the security of the data, and we've discussed that. And also, they're concerned about whether or not the data can be hijacked by certain entities in the government, since Lyme is so controversial and so different than any other disease that most people in government have ever seen. So could you just expound upon that for everyone?
Yeah, those are both great questions. So the first one has to do with privacy and security. And we regard ourselves as having made a social contract, essentially, with patients who are in the registry for a number of things, not only to protect their privacy, secure their data, but also to make sure that the data is used for the benefit of patients, which means that we vet researchers. So we want to make sure that researchers who come in are doing unbiased research, and certainly that nobody's going to be misusing information to harm patients, as we've had in the past in prior research studies. The second question is, is really much more about security, and we're with an NIH-approved patient registry platform. It's met the standards of not only HIPAA, but something called FMSS, I think is what it's called, which is just a very high level of security. This means, the servers are in a room, there are guards outside the room, it's a very secure environment. We take it very seriously. There have been a lot of data breaches that have occurred. For instance, Aetna has had data breaches. A lot of times, the way that those are happening is through very sloppy practices. Data ports left open, laptops left at the airport. So all of those sorts of things we're being very mindful of. Researchers who work with us have an obligation to sign a data user agreement that also limits how they protect the information, where they store it, are they taking it home on the bus, that sort of thing. We're extremely mindful of it. I think it's a very big issue, particularly when you're dealing with a marginalized community like Lyme disease.
Thank you.